My today's talk is untraditional, like most of the time I am on pregnancy diabetes, so this is little untraditional talk for given to me, and we'll try to do justice to this. Evolving evidences with DPP4 inhibitors, implications on the clinical decision making, and this is my disclosure. You may take photographs if you wish. The complexity of type 2 diabetes is very well known to everyone, and the omnious octet, and now you have more risk factors and pathogenic mechanisms which have been added. We as an Indian, we have a different phenotype. We have more visceral obesity. We have more insulin resistance. We are centrally obese. We have to consider hypoglycemia, renal functions, diabetes associated, type 2 diabetes associated with comorbidities. Tolerability, adherence is a big issue across the country. Then dose adjustment is another thing whenever you talk about any patient who has renal impairment along with the type 2 diabetes, and then complex pathophysiology, and we have to address all of these pathophysiological mechanisms and these factors which are responsible for type 2 diabetes whenever you try to address glycemic profile, or you want to address glycemia in patient with type 2 diabetes, along with the other benefits, what we have heard from Professor A.K. Singh, and next is going to be Shashank, and the wonderful debate we had earlier. So whenever you try to treat a case of type 2 diabetes, you have to look into various factors. It has to be individualized. That's one message. It cannot be one particular basket may not be used for everyone. You have to take care that whatever drug you're using should not cause weight gain who the person who's already having obesity. We have to also take care of comorbid conditions which are associated with type 2 diabetes. Risk of hypoglycemia, the therapy should not increase the risk of hypoglycemia, and that's what most of the global recommendation says, that whenever you try to achieve euglycemia in a patient with type 2 diabetes, you should avoid that the risk of hypoglycemia should not increase. Cost, of course, is a big factor, and in debate we have heard wonderfully well about the cost. In India, of course, we have lower cost than in the Western world, but still we have to face this issue. Polypharmacy and adherence, very important. Most of your type 2 diabetes, they have diabetes, they have hypertension, at least they have 2 or 3 anti-diabetic drugs. They have antihypertensive drug. They are on statin, most of them aspirins, and the list goes on. So adherence is important. Most of the times when we try to give a medicine, it is likely that they miss out. I can give an example of insulin therapy. The moment I put the patient gets admitted in our hospital for say basal bolus therapy for any other reason, and if you discharge these patients on basal bolus therapy, invariably out of these 4 pricks per day, they will stop 1 or 2 in the afternoon on the breakfast insulin doses, and that is a common phenomenon across, and need dose adjustment. Any therapy you should choose, see to it that the dose adjustment is not a common phenomena with everyone. If something which fits to all kind of EGFR patients or all kind of patient with safety profile, I feel that makes more sense of prescribing a drug. So there is a need for glucose lowering medication, which simplifies the management owing to the busy clinical practice. So any drug which should have a good glycemic control, which should be at least weight neutral, low risk of hypoglycemia, no dose adjustment irrespective of the EGFR, CV safety, and kidney safety. If you have all these 6 basic properties in a drug, I feel that can be a drug of choice in a given case. Now, let us talk about DPP4 inhibitors, which plays a very important role, almost now more than a decade. Low risk of hypoglycemia, they are weight neutral, cardiovascular safety data we have, safety profile as compared to placebo, few interactions with co-medications, no timing or dosing issues when it comes to linagliptin, and the compliance, because if it is a single dose therapy, it can be acceptable. Now, evidences, let us go through the evidences of safety. Now, this is a comparable efficacy of DPP4 inhibitors. Now, you talk about Lina, LO, Saxa, Sita, or Vilda. All of these gliptins, the glucose lowering efficacy has been consistently shown quite good, and it's around 0.7 to 0.8. Now, when you talk about Asian phenotype, somehow our population gets benefit more versus the Caucasians, and the HbA1c reduction in Asian versus Japanese versus white population seem to be higher in Asian cohort versus the Caucasian or Japanese cohort. So you have 58.2% of Asians were Indian in the Asian cohort, which is applicable for our population. Similar trough concentration throughout. 24 hours DPP4 inhibition is seen with the drug by almost more than 80%. And almost adverse events are almost similar in all the population. So it makes sense that when you talk about DPP4 inhibitors, try to choose more commonly in Indian population when it's going to be more beneficial. Now, do all DPP4 inhibitors available to you? Now you have sitagliptin, vildagliptin, saxagliptin, elogliptin we don't have. We have linagliptin, and we also have now teneligliptin available, and more gliptins might come in the market. Now, let us talk about those drugs which we have the data available. And now as far as the similarities and differences, as far as efficacy is concerned, weight neutrality is concerned, hypoglycemia is concerned, tolerance is concerned, most of the DPP4 inhibitors they have almost the similarity. But there can be differences in PK/PD, there can be differences in CV safety. Some of the molecule might not have the CV safety data. Heart failure started with the sevotemy of saxagliptin, and now we are supposed to, most of the gliptins are supposed to show that the drugs does not increase the risk of heart failure, and of course the kidney safety. There can be differences between the two, all these gliptins. So, which is with its unique mode of elimination, linagliptin is the only available DPP4 inhibitor that does not require the dose adjustment for any stage of renal impairment. Whether you talk about the stage 1 or stage 2, or whether you talk about the end-stage kidney disease. You don't need to adjust the doses, and I am not into a fear or a phobia of prescribing a drug to a person whose EGFR is 50 and might land up with less than 40 any time. And above 45, you don't need to, you need to reduce the, below 45, you need to reduce the dose. So I'm not much of the worried, and most of the, when it comes to compliance of visit to the clinic, it is quite less in India versus other countries. I'm not sure, but in India, once you prescribe a drug, patient doesn't come back to you as often as you want them to come back for the review. And that is why a single episode of gastroenteritis, a single episode of dehydration with a summer of 48 in Nagpur, it becomes very difficult for us to maintain. And that is why it is always fair to give a drug which is renal safe, where you don't need to reduce the dose and don't need to worry about reducing the dose when EGFR goes down. When you talk about Sita, Vilda, Saxa, or elogliptin, all of them, they require dose adjustment. Now, one thing is very clear. Every gliptin can be given in patient with renal impairment, but you need to adjust the doses. So almost 75 to 80% of these drugs, they have the renal excretion, and then we need to adjust the doses. Now, as far as PK/PD is concerned, linagliptin has the highest potency to inhibit DPP4 inhibitors with the smallest tablet of 5 milligram. And the linagliptin has a leading selectivity for DPP4 inhibitors to DPP2, DPP8, DPP9, and least off-target inhibition, the risk is much less. And then it has a lowest free drug concentration versus Saxa, Sita, and vildagliptin, and that's why you have less free drug available in the circulation. So it's more safe. Now, evidences and the dose adjustment in renal impairment. When it's a mild, moderate, or severe, linagliptin don't need to change the dose. Dose remains as 5 milligram once a day. When it is sitagliptin, you have to come down from 100 to 50 in moderate, and in severe or ESRD phase, you have to come down to 25 milligram. Saxagliptin, 5 milligrams, you have to come down to 2.5. Vilda, 50 milligram twice a day is the actual dose, but you have to come down to 50 milligram once a day. Teneligliptin did not need to be changed. The dose need not be changed. But then we have to also see the safety part of it. Clinical concern, linagliptin efficacy is established in all stages of renal impairment, including even a patient on hemodialysis. Other drugs, we have to adjust the doses. There is no dose adjustment which is based on PK, but no safety or efficacy data available from the teneligliptin. You have a question mark about QT interval when we talk about the QT prolongation, when we talk about teneligliptin, liver enzyme elevation, sometimes hyperkalemia, and the risk of renal impairment. So we don't have a good safety long-term data available for teneligliptin, and that's why we have to be a little more cautious while prescribing a drug, though it is being recommended by the DCGI. CV outcome trials, let us talk about CV outcome in DPP-4 inhibitors. So you have Savortimi, you have Examine, you have Ticos, and you have Carmelina. Savortimi, I feel, I won't be going into detail of it, but the primary endpoints, if you see 3P MACE, 3P MACE, 4P MACE in Ticos, and Carmelina, you have 3P MACE. And secondary endpoint, you have 5P MACE, 4P MACE, 3P MACE, and the composite kidney endpoint in Carmelina. So Carmelina have involved the patient with renal impairment. So Carmelina has shown a reassuring long-term kidney safety profile when it comes to linagliptin. And this is a data which has shown the pre-specified adjudicated kidney composite outcome. This is the other DPP-4 CV outcomes are there in all of these gliptins, they have shown the ESKD, the end-stage renal disease, renal death, more than 40% reduction, decrease in EGFR. It has been shown that it is neutral. ESKD renal death, there is benefit. Microvascular composite outcome, it has shown that it is beneficial to linagliptin. And albuminuria progression, probably this is the point where you have got statistically significant benefit, as well as composite point, microvascular, pre-specified microvascular composite point, they have got the statistically significant positive points in favor of linagliptin. Now, CV outcome, Savortimi versus Ticos versus Carmelina. I'll just focus on the patient with history of prior heart failure and patient with history of prior CVD. It has shown that the most of the number of the patients and the heart failure is 27% here, and the patient with CVD 57%. And Carolina have almost 40% of them, they had CVD in the past. If you talk about the Ticos or the sitagliptin data, almost 100% of them, they had the CVD. So when you talk about in your practice, you have mixed population, almost 20 to 30% might be having a pre-existing CVD, and rest of them either will have risk factors or will be free of CVD risk factors as well as CVD disease. And that is why the data of Carmelina as well as Carolina has actually satisfied us when it comes to patients who are normal as well as patients who are at higher risk of having heart failure or CVD, and it has shown its safety. Saxa, LO, Sita, and linagliptin has shows reassuring data as far as CV safety is concerned, whether it's Savortimi, Examine, Ticos, or Carmelina. Almost they have shown neutrality, and the non-inferiority has been well proved. And it has been shown that all DPP-4 inhibitors, as far as the CV safety is concerned, seem to be okay to us, and it's reassuring. Now let us talk about heart failure. It is the Savortimi and alogliptin data from Examine. This has actually frightened us, and there were a lot of debate and discussion in the early stages when these data were published. And that is why most of the gliptins then have to prove that there is no high risk of heart failure, and that is why then Ticos and Carmelina, Ticos has come. Ticos has shown that there is no risk of heart failure in patients who have been given sitagliptin, and then Carmelina have recently been published, and it has shown that there is no risk of heart failure in patients. So we can say that when you talk about heart failure, it is not the class effect that all DPP-4 inhibitors will be behaving as that of Saxa or LO. Rather, there is a safety data available from Ticos and Carmelina that the sitagliptin and linagliptin seem to be safe as far as heart failure is concerned, and linagliptin has shown some beneficial effect in patients with heart failure. So linagliptin has consistently shown no increased risk of hospitalization heart failure, and because regardless of the baseline, whether they had a compromised heart failure or whether they don't have, and whether almost 27% of this population had history of heart failure, 74% of the population had renal impairment, and almost 57% had ASCVD, and 65%, many of the patients were more than 65 years of age. So irrespective, you have background heart failure, irrespective you have renal impairment, ASCVD, or elderly population, there is a benefit. This is the heart failure profile in various population, North American, Asian, and they have shown that there is reduction in the risk by the hazard ratio is 0.6. In Asian population, hospitalization for heart failure, 0.47, so it is beneficial. And those who are not on insulin, even in those population with history of heart failure, hospitalization was less. So now clinical implication of Carolina as well as Carmelina. If you just talk about the Carolina profile of patient and Carmelina profile patients, Carolina is a group of individuals where the disease is quite early. 42% had severe risk, and 37% had more than two risk factors. 40% had type 2 diabetes of less than 5 years. 9% were treatment naive. There was no patient on insulin therapy, and metformin almost 83%, and it was compared with the glimepiride. While Carmelina is a more risky population, with almost 74% of them they had kidney disease. 57 had CV disease, 33% had established CV disease and prevalent combination of the two, and less 3% of them they drug naive, 55% on metformin, and almost 60% of them they were on insulin. So if you talk about the linagliptin as a drug, Carolina and Carmelina has covered almost all group profile of a patient coming to you with type 2 diabetes, early disease as well as the advanced disease. Now, together, Carmelina and Carolina have demonstrated the long-term safety profile of linagliptin, whether it's 3P MACE, hospitalization for heart failure, or CV death, all-cause mortality. It has shown to be safe. Carmelina and Carolina is again 3P MACE, hospitalization for heart failure, as well as all-cause mortality, has shown that the p-value is less than 1. And that is reassuring data for when you use this drug in any patient with type 2 diabetes. Now, so we have seen that there's around 7,000 patients in Carmelina, almost 6,000 in Carolina, and 2.2 years duration Carmelina and 6.3 year duration in Carolina. And this data has given us assurance that this particular drug seemed to be the safe as far as the gliptins is concerned, as far as CV outcome program is concerned, and even the renal parameters and heart failure issue is concerned. So question from an expert is, we documented the markedly reduced rate of hypoglycemia with linagliptin compared with glimepiride, because in Carolina you have glimepiride as comparator. Weight gain differences, are they important? We'll just go through, and durability of the issues. Hypoglycemia, I won't go in detail of it, but hypoglycemia is of concern for all of us, and that is why, and it's not just hypoglycemia, it's the increased hospitalization risk, increased cost, and decreased quality of life when the patient develops hypoglycemia, especially when it comes to moderate to severe hypoglycemia. So, hypoglycemia can cause fall, fractures, hospitalization, cost, fear of hypoglycemia, quality of life may interfere, and of course uncertainty about CV risk when you talk about advanced program and the earlier ACCORD program, where we have seen that the hypoglycemia has been labeled as one of the risk factor for a CV event. So sulfonylurea use is associated with increased hospitalization when we talk about glimepiride or any other sulfonylureas, and hypoglycemia is a big concern, and that is why we have to be very, very careful when you use a drug which can increase the risk of hypoglycemia, and this is a Carolina data where they have shown that there is increased risk of hypoglycemia. Now, number needed to treat. If you have minimum number to treat a patient to save a person from hypoglycemia, that's the best drug. And if you talk about here linagliptin versus glimepiride, the number to treat is on any hypoglycemia, it's only 3. Moderate to severe, only 4, and very severe hypoglycemia, 45. So what this means is the drug which is causing less risk of hypoglycemia versus a glimepiride where 1 in 4 patients treated with glimepiride will have moderate to severe hypoglycemia, and that is why we have to be careful. Body weight, again, glimepiride or any sulfonylurea might increase the risk of weight gain, and this has been consistently shown even in this diagram of Carolina, that there is a weight gain which was not there and which was rather less in patient with linagliptin. There was weight was reduced. Comparable to long-term efficacy of lina and glimepiride, the durability, if you see, there's early stage you have reduction in blood glucose, but in the later stage, the consistent maintaining the blood glucose from 7.16 to almost 256 weeks, it has shown that it is giving more consistent control versus the glimepiride. So it's better as far as durability or sustainability is concerned. So overall conclusion, linagliptin was superior to glimepiride. Over a third of glimepiride treated patients had hypoglycemia. Linagliptin was associated with modest greater weight loss, and it supports DPP-4 inhibitors before sulfonylurea. It is better. You have also real-world evidences, which again I'll not be able to go in detail because we have now time is going up. So even real-world data has shown, and it has been translated. Whatever has been shown in the randomized control trial, phase 3 trial, has been translated into the real-world data also. There was 24% reduction in CV risk. There was 26% reduction in hospitalization to heart failure in the real-world data of linagliptin. So in toto, when we finalize, then it is the, when you talk about vildagliptin, saxa, teneligliptin, or sitagliptin, the safety profile is still missing out when you talk about vildagliptin, CV risk, heart failure, and high kidney risk. Saxagliptin, you have a problem, we have problem with the heart failure. Teneligliptin, safety data for CV disease we don't have. Heart failure, kidney disease, we are uncertain. Sitagliptin is again kidney disease is uncertain. Linagliptin, you have a data, monotherapy, dual therapy, triple therapy. You can have the safety data available for CV risk, heart failure, as well as kidney disease. With this, I stop here. Thank you very much for your patience listening.